Good morning. My name is Enid Eslick, and I'm the medical physicist in the Department of Theranostics and Nuclear Medicine at St. Vincent's Hospital, Darlinghurst. I greatly appreciate this opportunity to present to you some preliminary data on a new study in our centre which is looking at the relationship between the external dose rates measured on the day of treatment administration and treatment response indicators, with the idea that we may be able to tailor the take-home radiation safety recommendations to best suit the patient and minimising the stresses associated with treatments. We want to ensure carer safety and public safety without the need of being overly conservative. Lutetium PSMA therapy is a treatment for men with advanced prostate cancer. Through pivotal trials such as the Phase 2 therapy trial and the Phase 3 Vision trial, this therapy has shown to have relatively few side effects, has improved quality of life and prolonged survival in most patients. This therapy uses small molecule peptide labeled with lutetium-177, which attaches itself to the PSMA receptors on the cancer cells. The therapy trials in Australia have been using urea-based ligands such as the PSMA 617 and the PSMA INT ligand. The PSMA 617 product is owned by Novartis and is used under trial conditions, whereas the PSMA INT is not under IP and is used on compassionate grounds for men who do not qualify for trials. St. Vincent's Hospital was part of the therapy and vision trials, and we are currently involved in 5 lutetium PSMA trials. We do approximately 200 plus lutetium PSMA treatments per year, and we have just started the ACTION trial, which has a therapeutic agent PSMA 617 labelled with actinium-225. This is our lutetium PSMA therapy protocol at St. Vincent's. So the patients receive a standard dose of about 7.5 to 10 gigs per treatment, with the average being about 8 gigs. The radiolabeled compound is administered by a slow intravenous injection, and it is recommended that the patients are hydrated pre and post injection with about 1.5 litres of water, and they're encouraged to void quite frequently. Each treatment is undertaken at a minimum of 6 weeks apart, and the patients are eligible for up to 4 cycles of lutetium PSMA treatment. External dose rate measurements are important for the determination of the discharge time to ensure radiation protection of carers and the public. The team at St. Vincent's have recorded dose rate measurements at various time points post-administration. This has provided a great opportunity to undertake a retrospective analysis to assess the relationship between dose rate measurements against treatment response indicators. In Australia, lutetium therapy is conducted in an outpatient setting, and this is not the case in other countries, such as Germany, where the therapy must be administered in an inpatient setting with a minimum of 3 days in the hospital. Patients are discharged with radiation safety precaution information when the external dose rate is 25 microsieverts per hour or below. Most centres provide radiation safety precautions for 5 days post-treatment day. Our patients return for a 24-hour SPECT CT. So the therapy trial reported that 66% of treated men experience a greater than 50% PSA decline. However, despite early data showing significant clinical responses, a proportion of men do not respond to lutetium PSMA therapy or have relatively short-lived response. It is therefore very important for clinicians to be able to predict how a patient may respond to this treatment for the purpose of better patient selection and also improving the therapy efficacy. For example, dose escalation may be an option. However, another good use of treatment response prediction is in the personalisation of radiation safety recommendations for the patients. Due to the COVID-19 pandemic, all of us now have a better understanding of the impact of social isolation on one's mental health. An isolation period of 1 week can be challenging, and various types of therapies have an isolation period associated with them. So I think if we can invest a little bit more time into finding the right balance between radiation safety directives, and the impact on a patient's quality of life, this will be beneficial for our patients. So just going back to treatment response markers, there is a lot of research in this area as clinical predictors of response remain poorly characterized. Screening imaging with PSMA and FDG PET are important tools in predicting if a patient will have a clinically significant response to treatment with lutetium PSMA therapy. Strong correlations were found between high PSMA expression on PET and greater than 30% reduction in PSA. Other factors such as homogeneity of PSA receptor expression across cancer cells could also be an indicator. No sites of FDG mismatch not expressing PSA is important. SUV mean at screening was also seen to be an important indicator. Men with low tumour volume responded better to treatment. High activity retention by tumours is likely to have a good response. And our study is also looking at rate measurements correlation with some of these treatment response predictors. Our study hypothesis is that a small dose rate change from the 0-hour to the 24-hour time point indicates high activity retention by tumours, which could result in better treatment response, but requiring a longer radiation safety precaution period to be in place. Conversely, a high dose rate change from 0-hour to 24-hour indicates low activity retention by tumours, which would result in fast clearance of activity and allow a shorter period of radiation safety precaution. So moving on to our results, we can see that the dose rate decreases relatively quickly within the first few hours. This is similar to what's been found in previous studies, where an initial fast clearance phase occurs in the first few hours, followed by a slower clearance phase. The dose rate measured within the first 30 minutes after injection pre-first void is approximately 40 microsieverts per hour, and the patients drink regularly whilst they're in the department. The discharge dose rate is usually reached within a few hours. The average dose rate at 3 hours is about the 25 microsieverts per hour mark. And at 24 hours post-injection, the average dose rate reading is about 10 microsieverts per hour. Previous studies have had similar findings. There are reports of the half-life of the initial elimination phase is about 2 to 5 hours, and the slow clearance phase is approximately 41 hours. So there is approximately a 50% excretion in the first 4 hours and a 70% excretion in the first 7 hours. Our analysis involved comparing dose rate means using the student t-test. The alpha level of significance was set at 0.05. Statistically significant univariate results were modelled using an unconditional logistic regression analysis adjusting for potential confounding factors. So using a decline of 50% in the PSA as a treatment response indicator, looking at the graph on the left, we can see that in cycle 1, there is a significant difference in the drop in dose rate from 0-hour to 24 hours in patients that respond to treatment compared to those that did not. And adjusting for EGFR did not affect this result. Looking at the graph on the right, which is the mean dose rate measured at a particular time point, there is a significant difference in the dose rate measured at 24 hours between treatment responders and non-responders, with responders having a high dose rate at 24 hours. Again, adjusting for EGFR had no effect. But we do not see significant differences in the mean dose rate measured at other time points. We also looked at cycle 2 data. The results of cycle 2 also show that there is a significant difference in the change in the mean dose rates from 0-hour to 24-hour for responders versus non-responders, and the non-responders having a greater change. And the mean dose rate measured at the 24-hour time point is also significantly different between responders and non-responders. And again, adjusting for EGFR in a logistic regression model did not affect the significant results. Comparing dose rate and total tumour burden, where high tumour burden was defined as greater than 400 mils, our analysis has found a significant difference in the dose rate drop from 3 hours to 24 hours in patients with low tumour volume versus those with high tumour volume. Patients with low tumour volume have a larger drop. When these results have been adjusted for eGFR and SUV mean, they remain statistically significant. Due to the small sample sizes at 0 hour, this may have contributed to the non-significant findings for the 0 to 24 hour results. With regards to the second graph, at 24 hours, there is a significant difference in the dose rate measured between the high tumour volume versus low tumour volume group, with a higher dose rate measured for the high tumour volume group. And now comparing dose rate and SUV mean, here again our results are affected by the small sample size. The graph is showing that patients with a lower SUV mean have a higher drop in dose rate. However, none of the results were significant. With regards to the dose rate readings at 0, 3 and 24-hour time points, there is a significant difference in the dose rate readings at 24 hours. However, when we adjusted for eGFR and volume, the results became non-significant. Some of the complications in our study are that we did not measure activity loss due to voiding, and we are yet to factor in BMI in our analysis. However, I think we have some interesting findings nevertheless. Cycle 1 and Cycle 2 dose rate drop was greater for non-responders, and the dose rate at the 24-hour time point was higher for responders. This correlates well with our understanding that responders should have a better tumour uptake. The SUV mean showed a higher dose rate at the 24-hour time point, which may correlate with better response. A higher SUV mean has been associated with better response. The total tumour burden analysis showed that higher tumour volume was associated with higher dose rate at 24 hours. What this means is uncertain, as higher tumour volume has been associated with worse outcome, but higher dose rate may be associated with better outcome. So taking all of this into account, there is potential of utilising dose rate values measured within 24 hours of treatment administration to guide patient safety precaution measures for patient upon discharge. It appears that quick clearance is associated with suboptimal tumour uptake, and therefore we can minimise the isolation period for these patients compared to those with good tumour uptake. So this is a preliminary study, and we hope to conduct further research in this area. I would like to acknowledge the many people involved in the study, the patients who gave up their time to allow multiple measurements to be taken, the cooperation of staff to collect data despite working in a very busy department, and previous medical physicists who have set up the dose rate measurement forms that have allowed for the data collection. Thank you.